My name is Gavin Roberts, and today I'll be presenting my quality improvement case study titled Reducing the Rates of Post-Op Infections After CTR. Carpal tunnel release is one of the more common outpatient procedures performed, and although the complication rate is generally low, infections can still happen, especially when communication or documentation breaks down during the post-operative period. Today I'm going to walk through a real patient safety case, explain what went wrong, and how a structured quality improvement plan can significantly reduce the risk of preventable post-operative infections. A quick agenda of what I will go over. I will start off with my SBAR summary of the case to clearly outline the situation, what led up to it, and why it matters. I will follow that with the root cause analysis, where I will look at the underlying conditions across the 6M's framework. After identifying what truly went wrong, I will walk you through my SMART AIM statement, which defines exactly what we hope to improve within the office. That will lead into my PDSA cycle, our structured improvement plan. From then, I will discuss the measurement strategy, how we will track progress, and know whether our intervention is working or not. I will also apply the switch model to show how behavior change can be implemented successfully among the staff within the office. And finally, I will cover feasibility and sustainability, explaining how this case can realistically be put into action and maintained long term. And I'll wrap it up with a conclusion summarizing the impact of the project. So first, for the SBAR summary, the patient began experiencing early signs of infection after her carpal tunnel release procedure. She reported redness, warmth, increasing pain, swelling, and eventually drainage. By the time she called the office, her concerns were dismissed by the medical assistant. There was almost no documentation of her calls, the surgeon was unaware of the severity of her symptoms, and no follow-up appointment was made. Because the MA was inadequately trained and operating outside of her scope by giving medical advice, the patient's symptoms were never escalated to a provider. This is significant because the red flag symptoms were entirely missed. The infection progressed until the patient eventually went to the ED, where she required immediate surgery, hospitalization, and ended up losing significant function in her hand. The recommendation is clear. The office must document every patient call, especially regarding possible infection, and establish workflow where red flag concerns trigger rapid follow-up with a medical provider. For the root cause analysis using the 6M's framework, I have under manpower, the medical assistant did not have adequate training needed to identify red flag symptoms and also operated outside of their scope by giving medical advice. Under methods, the office did not have a standardized workflow for documenting patient concerns. Machines refers to the absence of electronic medical recording tools to track post-op symptoms or call documentation. Materials were also lacking in the sense that the MA had no checklists, no visual cues, and also no guidance for identifying infection warning signs. For measurement, the practice did not track time between patient calls and provider responses. And finally, under Mother Nature, a busy workflow and high call volume increased reliance on the MA, allowing the symptoms to be overlooked. All of these factors pointed towards the root cause, that communication failures and absence of a structured documentation and escalation procedures. For my SMART AIM, it defines what we need to improve within the office, and specifically, we want to ensure all patients' post-operative calls, particularly those involving red flag symptoms or infection concerns, are documented and reviewed by a provider within 24 hours. Measurably, our goal is to achieve more than a 90% timely follow-up, and this will be monitored by having a provider sign off on each documented concern from the patient. The aim is achievable because it doesn't require hiring additional staff. The office can simply organize a documentation checklist and incorporate it into existing workflows. It's relevant because communication failures directly cause delayed treatment in this case and severe patient harm. And finally, it is time-bound because with implementation planned for within 1 month, it can be supported by bi-weekly data reviews. Overall, the SMART AIM lays out a clear, actionable objective that directly targets the root cause of the problem. For my PDSA plan, it's going to outline our step-by-step approach to implementing change. In the plan phase, we are going to create a documentation tool that allows the medical assistant to record symptoms, dates, previous visits, and any concerning details reported. In the do phase, we are going to train our MAs to identify red flag symptoms, properly document them, and also the training will reinforce the limits of their scope and the importance of passing urgent symptoms to the providers. During the study phase, we observe and measure key outcomes, specifically the time between a patient call and provider response, and whether the number of repeat calls decreases, suggesting a better resolution. And finally, during the ACT phase, if our goals are met, we can expand the system by incorporating EMR tools such as MyChart, which would allow patients to submit their concerns electronically. This would be easier for patients and address different social determinants of health they might have, and the red flag messages would be routed to a provider immediately, while non-urgent messages would be handled within the next 24 to 48 hours. This cycle will allow us to test on a small scale before making any broader changes within the workplace. For our measurement strategy, it is essential for knowing whether our intervention is actually improving patient safety, and we will measure this by focusing on the number of documented calls and the ratio to red flag symptoms to provider responses. This will tell us how consistently the documentation tool is being used within the workplace. Our outcome measure is the reduction in post-operative infection rates. If we see infections decrease after implementing this plan, we know the intervention is effective. The balancing measure ensures we're not intentionally overwhelming staff. We need to confirm that documentation isn't increasing MA workload or lengthening patient wait times. Our data will be collected monthly, displayed using bar charts for infection outcomes and run charts to show changes in response time over several weeks. This visual tracking helps us identify any patterns we might have, our progress, or even our setbacks, allowing the team to make real-time adjustments when needed. For the switch model, it's going to help us understand how behavior change among the staff can influence the outcomes. For the rider, the logical part, we provide clear direction. This includes an MA documentation rule, a provider response rule, and monthly audits to ensure accountability. The elephant, the emotional motivator, we build buy-in and celebrating success. When providers recognize how MA documentation directly contributes to reducing infection rates, morale within the workplace will significantly increase and the staff will feel ownership over the improvement. And for the path, which is the environment, we will create conditions needed for success. This includes hands-on training, shadowing providers, office visuals showing common red flag symptoms, and overall these cues will support consistent behavior and help staff stay aligned within the workflow. By addressing all three of these components, we can create a change strategy that is logical, motivating, and successful. For feasibility and sustainability, the intervention is highly feasible because it relies on the staff already working in the office, and estimating that it will take about 2 to 4 weeks to train the medical assistants and fully integrate the new documentation workflow. That leads me to our main barriers, though. We anticipate staff resistance, as realistically would happen in any workplace, and some may feel that this adds extra work or disrupts their existing routines, but this is a clear example of why shared accountability and leadership support are essential for this to work. Everyone needs to move together to create a change, and to maintain these improvements long term, the team will review infection rates monthly and address any issues that persist. This ongoing analysis will help us identify problem areas early and make the necessary adjustments we need to keep this working. After the first month of implementation, if the intervention is working, we can expand the process to other outpatient procedures. We can also incorporate training into the onboarding process for the medical assistants so that they know this new workflow from day one. So overall, this case highlighted how breakdown in communication and documentation led to a preventable post-operative infection that resulted in serious patient harm. And we identified the root causes and built a structured QI plan. We developed an intervention that standardizes MA documentation, It strengthens provider oversight and ensures that from now on, red flag symptoms are never missed again. This project not only improves postoperative care for CTR, but also creates a safer and more accountable clinical environment. Through ongoing training, structured workflows, and a continuous measurement of our intervention, we can significantly reduce preventable infections and create lasting improvements in patient outcomes. Thank you.